This program is brought to you by Emory University.
Good morning, everyone, and welcome to another exciting Heart and Vascular Grand Rounds. This is part 4 of Dr. Dan Sorescu's lectures to us. He's had 3 that are posted on YouTube, I believe, for those of you who are interested in reviewing those. Dr. Sorescu has been with us at Emory for over 20 years, as we were just discussing. For 15 years, he was a fellow in faculty and in the basic sciences. And Dan was conducting research with independent lab funding from NIH and AHA, co-chairing several AHA sessions and focusing on NADPH oxidases and cardiovascular disease. He had a particular interest in cardiomyopathy and factors that lead to lifestyle-related cardiomyopathy, fatty liver, and heart failure. He's published over 30 papers and abstracts in this area and also impressively received 2 Millie Pub Club Awards. And for those of you who don't know that, those are it's an internal Emory Award for people who have had over 1,000 citations for their papers for high impact work. Dan's also been a pioneer, so to speak, developed the inpatient heart failure service at Midtown, which eventually became a teaching service for fellows and then residents. He's received numerous teaching awards from fellows and residents, and he participates actively in the grand rounds for residents and ECHO conferences there. Also has educational lectures for patients, which I think is really unique. He's created YouTube channel material for heart failure education for fellows, residents, and for patients, and has received the James Steinberg Award for Outstanding Clinical Achievement last year. Dan says that his passion is to be able to take complex scientific data and papers and make it simple for the audience. And so for today, I'm looking forward to this talk about Dan's thoughts on omega-3 supplementation and cardiovascular protection. So I'll turn it over to you.
Thank you, Pooja. As always, you're very kind. So I want to make I really don't have any conflict of interest. However, at the end of this lecture, I think I'm going to ask you to cut the sugar and refined carbs, cut the seeds oil, eat marine fish 3 times a week, and exercise 30 minutes daily. And I think if one can do this, it's probably more impactful than any drugs we've ever had in prevention of cardiovascular disease. I'm going to try to convince you over the next 45 minutes or so of this statement. Basically, we're going to review the clinical trials with omega-3s. We're going to go over some possible mechanisms, how they really work, and I'm going to go over how to do that. If you remember last time in part 3, I really submitted to you that if we want to look into what causes cardiovascular disease and chronic diseases in general, we ought to have a global integrated perspective of human health and disease. And I submitted, based on Professor Nick Lane from University of London in college, the mitochondria are our biological clock, and they determine not just the cell, but also our organism fate. And you can really think of mitochondria as a big Tesla battery. This is supposed to lasts for about 500,000 miles and has a limited maximum amount of charges and recharges. It's supposed to last us for a lifespan of 120 years. However, risk factors basically shorten the lifespan of this battery. And what really is important is that no matter what disease we look at, chronic illness, there's always a substrate of mitochondrial dysfunction, and 3 elements that are essential: oxidative stress, inflammation, insulin resistance. And I know these are like big words that we don't measure as surrogates in our day-to-day practice, but I'm going to try to give you some equivalents so you'll see that actually we do measure them, we just don't interpret them that way. And I thought, I've always had this approach, and this is why I wanted to do basic science, because I think, particularly with complex diseases that takes decades to develop, it's always good to have not just an isolated clinical trials perspective, but actually more of a assess the totalities of evidence-based medicine, also from the physics, biochemistry, cellular biology, and physiology perspective. But first, what I learned that we can really learn the best from clinical trials is clinical trials are excellent to learn from what applies from basic science and was really constitute the main mechanism of human disease. So let me give you an example. For example, in acute coronary disease, which is ST elevation myocardial infarction, we learned that after we started to do PCIs and drug-eluting stents, that really the residual mortality in this patient dropped from 13 to 1.8%, which means 86% benefit from therapy, 14% not being improved by therapy. So this over 50% benefit is telling you that the main mechanism of this disease is acute occlusion of coronary artery, and this is what we focus on. For example, chronic heart failure, systolic heart failure, the mortality drops from 35 to 10%, which is 71% by 5 years, which means the main mechanism of disease progression in chronic systolic heart failure is stress hormones and insulin resistance. This is how the combination of 4G-DMT drugs work. Now, let's look at chronic coronary disease. Really, the best outcome data so far, we have a Fourier on these 8 trials. They try to target an LDL to 30 to 50 milligrams per deciliter. One is chronic coronary disease. The other one is more of a post-coronary syndrome. Anyway, no matter how hard we try to push that LDL down, you only get 30% benefit from treatment. What I like is to look at the residual risk. Here is 9.8% out of 11 is actually, to my surprise, 87% of patients are not improved by therapy. So I'm sorry, probably even if we succeed at dropping LDL to 0, it's not going to make a difference here without horrible side effects. So I don't think that dropping the LDL and continuing to do that is going to make a major impact, because even when you do it so vigorously, it doesn't seem to impact the main mechanism of coronary disease progression. So this is what I'm interested in. What is that residual risk and how we can impact it? And I want to show you a slide from a study we did as we published in the last year fellowship in circulation. I was back then a young scientist in Kathy Greening's lab, my mentor, who's been a phenomenal mentor. And basically, I want to show you that coronary disease requires 3 elements: oxidative stress, insulin resistance, and inflammation. And this basically, we harvested human coronary segments from over 20 patients who underwent heart transplant. And we measure within 30 minutes, actually harvesting the level of oxidative stress. Here is superoxide. Notice this is a normal coronary segment, artery segment. This is a plaque that has causes 50% occlusion of the lumen. And here in red, notice there's a lot of oxidative stress right at that shoulder, which is supposed to be prone for a fracture and cause acute coronary syndrome. And if you look in this one here, this is a normal coronary artery segment. This is a plaque that's evolving. You see how there's intense staining in the shoulder in the plaque. We were the first to identify and show that the substrate of this superoxide production was actually the NABH oxidases, both phagocytes from macrophages, but also non-phagocytic from smooth muscle cell, endothelial cell, and fibroblasts that contribute to this oxidative stress in these arteries. But what really was interesting, if you look at in this intimal part of the plaque, you have a lot of smooth muscle cells that have migrated. Now, this is very different from this differentiated smooth muscle cells. As a matter of fact, in another study, the Rosa Klempusch, same in Kathy Greening, isolated these human coronary arteries and put them in culture. And you see that in the first passage, they all express differentiation in markers, but also this NABH oxidase called NOX4. Then these contractile myocytes, just like cardiomyocytes, actually require normal insulin, normal glucose. They use glucose and fatty acids for contraction. And the ATP is produced in Krebs cycle. That means in mitochondria. In contrast, if you keep passing and dividing these cells in culture, they start to lose the differentiated phenotype. They become, it's called synthetic or fetal dividing smooth muscle cells. That's completely different from the other one. And it's really a phenotype that we notice in those intimal plaques that is prone for growth, inflammation, fat storage. And here the glucose use is no longer done for the purpose of making ATP for contraction, but actually just like in Krebs cycle, it uses reverse Krebs cycle to actually put back acetyl-CoA to use that acetyl-CoA for DNA, RNA, and protein synthesis. And really, the main substances that converts one cell to another are actually hyperinsulinemia, angiotensin 2, cortisol, inflammation, oxidative stress. Do we have noticed the same kind of phenotypic changes, not just in smooth muscle cells in coronary disease, but also adult cardiac myocyte to fetal phenotype in cardiomyopathy, quiescent fibroblasts go into synthetic phenotype myofibroblast in human cardiac fibroblast. T cells also undergo a change towards T17 cells, which are pro-inflammatory. This is work done by Dr. David Harrison, who used to be at Emory, and also macrophages. So overall, if you look what's the setup for these cells to start being active and change completely their job and their role, is actually a it starts with hyperinsulinemia, insulin resistance, and inflammation. And if you look here on the left, it's a normal pattern of insulin release from somebody who's metabolic healthy. If you look here on the right, it starts to have hyperinsulinemia, then eventually insulin resistant. This for 10 years will eventually lead to prediabetes. And once hemoglobin A1C is over 6.5, now we call this type 2 diabetes. So why is it that insulin has to be released each time there's a glucose spike over 125 milligrams per deciliter in bloodstream? Very easy. Just like hypoglycemia is toxic, that can kill us right away, hyperglycemia is actually toxic to every cell in the body. And insulin is there to protect actual cells and tissues from hyperglycemia. It puts it back immediately in the stores. And if you keep on somebody who's got persistent hyperinsulinemia, eventually the excessive glucose that has not been able to be deposited in the fat starts to accumulate and starts to bind proteins in our body. And one of the examples is hemoglobin A1C. We call this advanced glycation end product. This is one of the mechanisms how actually hypoglycemia causes progressive end organ damage. The other mechanism is actually glucose, insulin. So basically, I was trying to make a point that insulin resistant that persists type 2 diabetes for at least 10, 15 years is toxic, not just through the hyperglycemia, but also through insulin being a growth hormone and not necessarily a glucose hypoglycemic hormone. And the fact that hyperinsulinemia has been associated actually with cardiovascular disease, or actually it's a major incremental risk factors, has been shown. Here is a study from New England Journal showing you that if your fasting plasma insulin level is less than 12, the other risk factors like a high ApoB would be high LDL or high triglycerides have minimal impact, increasing coronary risk. However, if the insulin goes higher than 12 or 15, suddenly this risk increases by 6 to 9-fold. And this has been known and hypothesized actually in 1988 by Dr. Gerald Revan, who was a famous endocrinologist at Stanford, who basically used to do insulin resistance studies. And it showed that in a dose-dependent manner, if you follow for 10 years, people who have no insulin resistance, mild insulin resistance, severe insulin resistance, those are the ones who develop actually cardiovascular disease. And he's the one who created the concept of metabolic syndrome. And now, more recently from Accelerate trial, it showed that those people, despite of high-intensity statin, those patients who progress with coronary disease and have more MACE, about 67% of them have progressed despite of LDL less than 70, but are associated with persistent elevated fasting insulin over 26 microunits. And most of that residual cardiovascular risk appears to be related not to the LDL, which is less than 70, but to triglyceride-rich laminin lipoproteins that you can measure it as a surrogate. The best surrogate marker actually for that is triglycerides to HDL ratio over 2.5. So I'm trying to propose to that improving insulin resistance is a key strategy for managing and slowing the progression of coronary disease. And I'm gonna mud the waters and make a bold statement that really coronary disease progression cannot be prevented unless we improve insulin resistance. So in the last 3 sessions, I tried to propose this hypothesis that was really advanced initially by Dr. Robert Lustig, that ultra-processed food causes insulin resistance, fatty liver, and coronary disease. And the main culprits in this ultra-processed food are high intake of fructose and seed oils. They're heated at high temperatures, but also make us eat more. And if we were to look at hard endpoints of cardiovascular outcomes, such as coronary disease, high blood pressure, heart failure, and mortality, any intervention that we are going to come up with to improve cardiovascular outcomes, one way or another has to impact ideally all three of them. This way we know that's going to work. And you can say, well, I can say all I want, but what's the evidence for this from prospective randomized study? And guess what? We have the evidence. This is my interpretation of actually two clinical trials. The SELECT trial, which was for coronary disease in semaglutide use in patients with prior coronary disease, morbidly obese. You drop the weight by 10%, improve coronary disease MACE by 20%. But if you look at the elephant in the room, the mechanism was inhibiting brain food intake, which is, I would say, whatever they were eating, including ultra-processed food, if they haven't changed the diet. So we impacted one mechanism. The other mechanism actually, and by far the most significant impact that was very little commented on, is that the incidence of new onset type 2 diabetes was dramatically reduced by 75%, and pre-diabetes was reversed by 60%. Other studies also showed that these agents, once you lose 10% of your weight, you also improve your fatty liver, insulin resistance, and triglycerides to HDL ratio. Now, looking on the other side, the heart failure with preserved ejection fraction, we have 3 clinical trials. They came in the last 2 years, most recent being SUMMIT trial. Again, the concept of morbid obese plus minus type 2 diabetes, a lot of them with pre-diabetes, heart failure with preserved ejection fraction, they lose 10% of body weight. In a year or two, you notice a particular SUMMIT trial was published in January this year, 35% combined cardiovascular death or worsening heart failure events. So there's a clear, strong signal here that whatever we do to reduce ultra-processed food in diet, improve fatty liver and insulin resistance, makes a major impact on cardiovascular outcome. As a matter of fact, this is such a potent idea that in heart failure with preserved ejection fraction, Journal of American Cardiology of Cardiology just published last week a whole issue on the hypothesis that heart failure with preserved ejection fraction, it's a disease that's caused by inflammatory conversion of fat cells that secrete cytokines and neurohormone that causes actually heart failure. So this is fat basically takes the role of creating overproducing neurohormone cytokines that then cause heart failure. And I proposed actually based on this last time we talked that because now we have evidence-based medicine for certain stages of progression of diabetes from cardiometabolic perspective, we could try to actually reclassify diabetes, not endocrinology, but cardiometabolic as stage 1, when we have some form of evidence of on the labs of insulin resistance or fatty liver. Stage 2, we have pre-diabetes, and stage 3 will be diabetes. Why? Now we have evidence that if we interfere with an agent at stage 2, we can prevent the stage 3. So that's some food for thought. I'm going to present you 2 patients, and I want to show you that there are other ways how we can actually approach this. Now, both of these 2 patients are basically end stage, either heart failure with preserved ejection fraction or non-ischemic cardiomyopathy, stage D. Both of these patients have a prognosis of less than 50% being alive a year later. The one on the left is 74 years old, prior history of CABG, type 2 diabetes that's poorly controlled, has an EF that's normal, severe pulmonary hypertension, chronic kidney disease, stage 3, high BMI. He's got an LDL cholesterol that's a target on high-intensity statin. However, his triglycerides are 4.8, the ratio is 13. And the first time I met him, we admitted him, we diuresed him 60 pounds. He went home. I tried to get him into buying into the diet, and he just kind of dished me off as I'm not eating rabbit food diet. Then 3 months later, to his surprise, we admit him again for worse heart failure. Turns out we had to place a stent in his LIMA to LAD for worsening coronary disease. The other patient is a 49 years old who basically I've had her for 20 years with type 2 diabetes on high 100 units of insulin since age 17. Well, I've watched her ejection fraction over 20 years drop from 45 to eventually 10, developed chronic kidney disease, stage 4, high BMI, we show sent home on palliative mirror after having over 20 admissions in that year in the hospital. And so both of them, I had a serious conversation. I was like, look, we're at the end of the road here. Can we please just try to work on lifestyle changes? So then we start working on them. And then as of the patients with heart failure preserved ejection fraction on the left, he lost about 100 pounds. Creatinine now is normalized in January. He still has nephrotic range proteinuria. His BMI is now 29. His type 2 diabetes has been reversed or cured, for lack of a better term. Triglycerides now, without any extra drug, but high-intensity statins, have dropped from 408 to 156, and the ratio is down to 3.6. Eventually, a few months ago, he decided that he's willing to copay for tirzepatide. He dropped another 14 pounds, but notice that majority of these changes of over 100 pounds weight dropped was without GLP-1 receptor agonist. He has had no hospitalization for heart failure or coronary disease in the last 3 years. States he feels best he felt in 15 years. What about the other one? Remember, she was literally sent home on home mirror with no other options at this point because of her high BMI, advanced chronic and heart failure disease. With changing her lifestyle and diet, using continual glucose monitor, I had to actually take her off insulin in 3 days. Her weight dropped in 6 months by 60 pounds. Her BMI has improved. Hemoglobin A1C dropped to 5.7. As of now, her hemoglobin A1C is 5.4. Actually, her diabetes also that she's had it for over 25 years has reversed. Her BMI now is 33. Now is able to tolerate GDMT. She's on submaximal dose of all 4 drugs with a NEF of 25-30%. Kidney function has reversed to stage 3. No hospitalization for heart failure since. Walks about 10,000 steps a day sometimes, but at least 6,000 every day. Couldn't do more than 20. And from 20 admissions in 1 year, none. So this was all lifestyle changing on top of the drugs that we usually use. And here is some sobering data. Last year, we had about 4,572 heart transplants, about 2,500 VADs out of a total heart failure population, reduced ejection rate of 3.5 million. That means we impacted a life of 0.2% with an estimated $12 billion cost. And obviously, we're going to try to do more and more. But again, no matter how hard we try, we impact very few of those patients this way. On the other hand, patients with morbid obesity, cost of GLP-1 receptor antagonists last year was $28 billion. This is estimated to treat less than 2% of total obese population in the country. Obviously, this is unsustainable cost. But the biggest and most worrisome data came from Dr. Mozaffarian at Tufts, who looked in 2018 at the metabolic health in the US adult population. And it turns out that only 6.8% had optimal cardiometabolic health, according to being positive for at least 3 out of 5 criteria for metabolic syndrome. In other words, we are at 93% of US adult population with cardiometabolic syndrome. So this is very sobering statistics. So what else can I do if we were to look into oxidized LDL hypothesis that causes coronary disease, according to Dr. Mason and Libby? About 20% of those particles now can be amazed, can be impacted by high-intensity statins and PCSK9 inhibitor. About 8 to 20% now. Hopefully, we'll have some data with genetically increased lipoprotein A. We know that we have drugs that can wipe out the lipid layer. We do not have cardiovascular outcome data as of yet. Hopefully, over the next year, we'll have it. But that's really the single most important majority of the 67% that seem to be actually the main mechanism mediating is some form of triglyceride-rich lipoproteins that feed into the small dense LDL. They're associated with insulin resistance and fatty liver. And the single actually most useful marker other than an ApoB over 70 is a triglycerides to HDL ratio over 2.5. So we tried to actually change that triglycerides to HDL ratio, trying to either drop triglycerides or increase HDL. And the clinical trials, they have looked either at fibrates, either at CETP inhibitors with the vastatrib, therapy or high-dose niacin or high-dose omegas really didn't seem to make any impact. And I'll submit to you is that in the absence of lowering insulin, these agents have not made any benefit because it's not the total levels that matter of these triglyceride HDL, but their composition and also whether we treat the cause, which is insulin resistance and fatty liver. Now I'm going to review the omega-3 supplementation clinical trials, and I'm not going to go into details. Suffice to say, we have a low-dose version, which is 1 gram. And here's on the left, it's the Italian study, risk and prevention study. The VITAL study was a Canadian study, which showed no benefit overall, just like the other one, except that if you look in people who have low fish intake, and particularly African Americans, there was actually statistical significant drop by 28% in myocardial infarction and 22% PCI, suggesting there is a signal there. Then when we look at supplementation, 1 gram omega-3s on diabetic patients, no benefit. Some hope of enthusiasm came with JELLYS trial, which was a large Japanese trial, patients with high risk for coronary disease or prior coronary disease randomized to low-dose statin versus low-dose statin with EPA at 1.8 grams. It did improve after 5 years by 19% MACE. And really maybe the most positive study that so far there's been today with omega-3s is the REDUCE-IT trial, which used 4 grams of icosapent ethyl, which is a special kind of EPA analog only that has a very high bioavailability. Patients with prior coronary disease or secondary prevention study, high intensity statin, extremely well-designed study, a whopping 25% reduction in MACE. And if you look at necessary number to treat, I did this calculation. I was honestly tremendously impressed because necessary number to repeat, when you look at mortality plus MI25, 3 patients that are required to treat to improve to reduce 1 myocardial infarction, stroke 5, mortality overall 50. Compared to statins, you see the high intensity statins, that number is all the way up to 39. And even if you add PCSK9 inhibitors, those to 36. So it's big difference. So all look too good to be true because unfortunately, STRENGTH trial, which was designed at Cleveland Clinic by Dr. Stephen Leeson, came out in JAMA in 2020 that showed that a combination of EPA and DHA on a similar patient population, although maybe not as sick from coronary disease perspective, it didn't show any improvement. So the conclusion was that the main criticism of the REDUCE-IT trial was actually that placebos used mineral oil as opposed in STRENGTH trial, the placebo was corn oil. And there's been some, and this use of mineral oil was associated with statistical significant about 25 to 30% increase in high sensitive CRP. They say, well, there you go, your mineral oil placebo arm was much sicker than the other guys, and that's why you got these differences. I'm going to come back to this at the end. I don't think that actually we have data showing that does not necessarily justify these differences. But for now, I want to remind you from last part 3 lecture I gave that I dare to propose to you the single most important, the greatest modifiable risk factor of coronary disease and accelerated aging is actually ultra-processed food, and would make a big difference if we try to just focus on that and eliminating from our diet or reduce it. And I'm not really the first to say that. That's Dr. Robert Lustig, who we talk in part 1 and 2 about fructose and ultra-processed food. However, on this particular part, I would like to focus a little bit on the role of trans fats and vegetable oils, particularly omega-3s and omega-6s. And the reason why I'm going to review a little bit of biochemistry for this, because this is where the devil is in details that matters. Basically, we have 2 types of fats: saturated fat, which are very difficult to oxidize at high temperature. All right. We have unsaturated fat, which is monounsaturated, the main one being oleic acid is present on olive oil. Then we have polyunsaturated fats, the omega-6s have 2 double bonds here that can easily be oxidized. And then omega-3s, linolenic acid starts at 3, but really the main ones are EPA and DHA, which have 5 and 6 respective bonds. So what's their job in the body? Omega-9 actually, it appears that it's cardiovascular neutral. However, it seems to help us burn saturated fat and actually maybe lose weight. Now, omega-6s are essential fatty acids. They're required for production of arachidonic acid-derived inflammatory substances that help us defend disease. We need them to make cortisol, sex hormone, cholesterol, cardiolipin, which is inner mitochondrial membrane, and importantly, endocannabinoids. Basically, it's our own marijuana is made from linoleic acid. And really, overall, I'll show you data. Their job is actually to help us store saturated fat. And in high amounts or oxidized, they can be pro-inflammatory proton body. In contrast, omega-3 appears to oppose all these actions. Obviously, they're essential for brain, eye, heart, and arterial function. In brain, the linoleic acid is actually replaced with omega-3, DHA. This is essential for synapses. Actually, omega-3 appears to burn saturated fat. They're anti-inflammatory. Now, the catch with all these omegas, whether it's 9, 6, or 3, is if you heat them up in a temperature over 350 degrees as oils or fat, they actually become oxidized. And not only become oxidized, they convert into aldehyde, which is the ultimate source of oxidative stress in any cell. And really, the olive oil does seem to do only half of the damage because it's got omega-9s. It's only 1 double bond, but it's not innocent either when it comes to this. And this is the potential danger with this vegetable or seed oils. Basically, the risk of oxidation correlates with the amount of omega-6s. For example, in sunflower oil, it's 60%. Then you see here, I plotted for you different numbers. Really, all the seed oils are bad. They have over 15%. Avocado oil goes down to 15%. Olive oil, it's about 13%. And really, the best ones would seem to have the least and theoretically are less likely to create advanced aldehyde products is tallow, coconut oil, and ghee and butter. And but other ways how this, although we know that heating vegetable oils can create trans fats, which are extremely toxic for our body. The reason is once you have a trans fat, there's no enzyme that either us or bacteria can metabolize it. And they are basically forever in your system and interferes with every other lipid metabolism you can imagine. But also, they create also the same trans fats, but also directly the omega-6 polyunsaturated fatty acids cause oxidized aldehydes. And I'm going to come back to why these aldehydes are important. But first of all, let's say if I eat something fried, does it really get even in our system? And the answer is absolutely. And the more diabetic you are, the higher levels actually you get. Why? Because diabetics have less antioxidant defense. Remember, elevated hemoglobin A1c means that your body is oxidized and has reduced antioxidant defense. And this is in a dose-dependent manner. In somebody who's healthy, you had a nice French fries and burger meal. They last for about 8 hours in chylomicron circulation, but somebody who's diabetic, it can last at least 72 hours. So clear, they circulate and stay longer in a dose-dependent manner. Now, this is the only slide I'm going to put about trans fats. Suffice to say they've been banned because they are bad for cardiovascular diseases. FDA has banned them from food products, but not yet because, for example, Crisco vegetable shortening, all right, is still present, including the American cheese, the famous liquid gold Velveeta. You can buy it from Kroger and everywhere else. And they present on the label as hydrogenated fully or partially, whether it's palm oil, whether it's soybean oil. And just always look for the keyword, buzzword is partial fully hydrogenate. Why? Because it's true, that's not trans fat yet, but that's if you heat up any of these, that's the next step is creation of trans fats in our body. So there, we still have a quite important source. By the way, it's present in field steak sandwiches that actually they try to get rid of cheese, and apparently this the only one that people want. It gives a lot of taste to the food. And here's the difference between a trans fat and a regular polyunsaturated fat. You see, the polyunsaturated one has this band that creates nice lipid wraps where the proteins can insert. This one looks just like a saturated fat, but it's got this highly oxidable double bond, which actually can easily be converted in environmental oxidative stress to aldehyde. And these aldehydes, they're a major problem. I showed you in first lecture how easily by frying our either chicken, potatoes, or fish, we can increase about 100-fold the amount of vegetable oil and oxidized omega-6. But this is the least of the worries, all right? Because if we look at potato chips, that's about 5 times more. And you also remember these are not only oxidized polyunsaturated, but also oxidized carbs. And we also notice there are some other interesting compounds into this, acrylamide and aldehyde. Now, why I keep bringing up the subject of aldehyde, here's why. When we look at smoking cigarettes and lung cancer, we actually have identified the mechanism how cigarette smoking causes lung cancer. And that's through the tremendous production of aldehydes that inhibit the DNA repair. Okay, this is an incredible potent carcinogen. So there is Dr. Grutfeld who is in England, a biochemist in England, has actually published this paper in Journal of Clinical Investigation, where it actually measures the amount of these compounds after you fry one portion of a small 150 grams of French fries. This is small size at McDonald's. So turns out it's equivalent of aldehyde that like you smoke a pack of cigarettes in just one small portion of French fries. I don't know about the meats and the other stuff. So basically, these are the same compounds that we've been incriminated for a long time that into cancer, but also and the main reason they're extremely potent, oxidizing the environment. So if you look at all these risk factors, to me, chemicals, fructose, alcohol, smoking, polyunsaturated fatty or trans fats, when they are heated up, they all convert one or another to some form of aldehydes, which are actually tremendous mitochondrial toxins and cause mitochondrial dysfunction. So that's a common pathway. We have at least 3 meta-analyses showing that in dose-dependent manner, eating fried food causes not only coronary disease, or it's associated with increased risk of coronary disease, but also heart failure. This is what our vegetable oil consumption started in 1902, moved from 0 when Crisco introduced the first cottonseed oil to, it's estimated by some that it could be all the way up to 32% of our daily calorie intake, while American Heart Association had put a maximum on how much sugar they recommend a day, 60 spoons for a woman, 90 spoons for a man. That has not been the case for actually seed oils and vegetable oils. As a matter of fact, although prior to 1902, most of the human diet was required only about 2% of calorie per day for these essential fatty oils. And our ratio back then was most of the time 1-to-1, less than 4-to-1. Today, we're at about 20-to-1 ratio between omega-6s and omega-3s. Despite of that, American Heart Association keep pushing that we got to eat mostly plant-based or seed oils and try to target around 10%. The ugly truth is we are at 25%. We actually have done that for the last 50 years. Some fact about linoleic acid is long-lived in adipose tissue. The half-life is 680 days. In other words, I still have linoleic acid from a nut that I ate 2 years ago in my fat. If there are actually studies that measure the linoleic acid content in adipose tissue, and compared to 70s, we increased from 7% to 20%. So I'm not sure why we keep pushing this up when we have done that and things are worse. Just to get an idea, an average American consumes 5 to 10 tablespoons of vegetable oil per day. That will be equivalent. That's concentrated if I were to eat 26 pounds of corn or 20 pounds of brown rice. And obviously, this would not happen if you were to eat whole foods because you'll feel full. So just like Paracelsus has stated over 400 years ago, the dose makes the poison, but also I would add to that how we process them, particularly we heat them up over at 350 degrees, and especially if we combine into what we call a sweet fat, is the sugar, the fructose, the refined carbs, and the polyunsaturated fatty acids. Now, these polyunsaturated fatty acids, like linoleic acid and omega-3s, have also a structural role in the lipid membrane of the cell and lipid membrane of the mitochondria. This is how they look like. This is a glycerol molecule. If you have two of those fatty acids, that's a phospholipid, essential to anchor insulin receptors or others. Triglycerides is how we transport our fatty acids in the bloodstream. But what I wanted to point out is this is called cardiolipin. This is a glycerol with 4 of these fatty acids. And why are they important? Because they polymerize under oxidative polymerization, and they create like a super glue where the electron transport chain of the mitochondria actually gets clustered so they can come close to each other. However, if we expose the mitochondria or the cells to high oxidative stress, they can undergo oxidative degradation. And that pretty much is a tremendous source for oxidative stress in mitochondria, and then causes mitochondrial dysfunction. And actually, there are some clear mechanisms that show they can trigger mitochondrial-induced cellular apoptosis. Now, one way how these omega-3s can help, and this is Dr. Preston, who is a biochemist at Harvard, has shown that if you take oxidized LDL, if you expose them under you take LDL and expose them under hyperglycemia clear oxidizes them more. But if you co-incubate them with EPA, that actually functions as an antioxidant, and it actually reduces the level of lipid hydroperoxide levels. So he stated the hypothesis that maybe the EPA, the way it works by incorporated between this lipid membrane, is able to kind of localize the oxidation in the small little compartments. Imagine instead of Second World War, you just have small little ballots everywhere, and that's what it's supposed to do. And this is a function just for the EPA, has not been proven actually for other agents that we use to try to reduce triglycerides, such as phenylfibrate, niacin, gemfibrobenzil, or vitamin A. So the way I would summarize this, think as omega-6s and as a fuel, think as hypoglycemia through the oxidative stress as a spark that oxidizes the omega-6, and things as omega-3s as dumping water. If you're on the firefighter is trying to limit the damage caused by the arsonists, there are hyperglycemia and omega-6s. So now, so one mechanism how this EPA may work is through a very potent antioxidant. The second mechanism is actually very potent anti-inflammatory too. Here are 2 studies with EPA, dose-dependent, 2 grams and 4 grams, Marine and Anchor trials. They look into markers of inflammation, like high-sensitivity CRP, goes down dramatically, but also reduces the oxidized LDL and improves a lot the dyslipidemia profile that's typical to a diabetic patient. So suggesting that will improve insulin resistance too. Now, I'm going to point one more impact of or essential role of linoleic acid. Back then, when we used to eat it seasonal from only seeds, nuts, or grains, the purpose of omega-6 turns to be actually to induce program obesity for the winter, so we can survive in a famine kind of conditions. Is similar signal. That's why I put it. This is evolution program number 2, because the first one is fructose based. So these 2 actually have worked together, and a recent study that came out in 2012, it showed that actually dietary linoleic acid is the main substrate to create our endogenous opioids, such as 2-arachidonic acid glycerol and anandamide, basically our own marijuana. And this actually go up upon exposure to linoleic acid. In a mouse model here, for example, they were given two different diets. One is both high saturated fat. One is 35%. That's an average for a human. This is 60%. And notice that they did not, and then they gave them 1% linoleic acid versus 8%. Notice that the one with 8% developed fat deposition and obesity, not so much the 1%, despite of being on the same high amount of saturated fat. And if they give them back EPA and DHA, that reversed part in a lot of this obesity. So what this suggests is saturated fat is there. It can be stored or it can be burned, depending on the ratio between the omega-3s and omega-6s. So that's an important factor. So then, sure, that how is that relevant to the humans? And actually, we have a prospective double-blind randomized study that proved this concept, that linoleic acid-derived cannabinoids, endogenous cannabinoids, we have a receptor for it, and we have a blocker for it. The first cannabinoid receptor 1 blocker was called rimonabant. First, they did a mouse study showing that it reverses obesity and fatty liver in mice. And then we have a prospective double-blind randomized study. It's called the trial is called RIO North America, was published in 2006 in JAMA, within patients who had cardiometabolic syndrome. They were placed on this rimonabant, and patient lost about 10% of their total body weight within a year. That's basically like Ozempic before Ozempic. And everybody was super excited because also the metabolic profile has improved. Cardiologists were ready to rock and roll and get on board to prescribe it. The catch is that in 2009, 3 years later, it had to be taken off the market because the same drug that the same cannabinoids that we use to stimulate our appetite is also used for pleasure reward center, and patients started to have actually suicidal ideation, had to be taken off the market. So there is some other evidence that linoleic acid is actually, and not necessarily the saturated fat, is what causes us to become obese in mice. There's another study in mice, that the reason I'm showing that study only look at obesity. This one also look at fatty liver, inflammation, insulin resistance. By just varying 1 versus 8%, the omega-6s, while saturated fat exposure stay constant, you can induce obesity, you reproduce dyslipidemia like we have in humans, elevated plasma triglycerides, cholesterol, insulin resistance, fatty liver, inflammation, liver fibrosis, but also our now well-known aldehyde, increased linoleic acid-derived aldehyde in the liver. When it comes to human studies, this is a study from Cleveland Clinic where they look at biopsies in patients with liver cirrhosis who underwent liver transplant. Turns out the most important predictive of advanced liver cirrhosis or NASH was the presence in liver biopsies of these oxidized linoleic acid metabolites. And that gave a risk anywhere between 3.5 all the way up to 27-fold. One more, omega-6 causing liver disease. There is a condition that's called fatty liver that develops in over 40% of patients we've been fed them with total parenteral nutrition, and it's often present in premature neonates. We have a short bowel syndrome, and it's been a clear link to the fact that the fat part into that TPN is actually soybean oil emulsion, which has a high 6:3 ratio. And if we can reverse that by giving them a fish-based oil emulsion, which switches from omega-3 to 6 ratio to 8:1. So again, it's the same conundrum that I've discussed. High amounts oxidized, omega-6 are bad, omega-3 are protected. So putting all this together, Dr. Ramsden has suggested, at NIH has suggested that, yes, if we try to replace saturated fat with vegetable seed oils in our diet, it seemed to clear, according to the Ansel-Keys equation, we drop the total cholesterol and LDL. However, there is a risk that we may oxidize that LDL and actually cause more cardiovascular disease, also cause more fatty liver. Wouldn't it be nice if we have prospective double-blind randomized study to actually test this hypothesis. And I'm going to present you two studies that I think they're very little known to cardiologists. I only learned about it a couple of years ago, to my shame. But I felt compelled that I got to show this. So there are actually two studies. One of them was actually designed originally by Dr. Ansel Keys. One is, it was called Minnesota Coronary Experiment. They were designing and has been completed from 68 to 73. There were over 7,000 people who were residents of nursing home or in psychiatric units who were randomized to test this hypothesis that vegetable oil and replacing saturated fat with vegetable oil for particularly corn oil and margarine can improve cardiovascular outcomes. That was the main hypothesis back then. And indeed, notice that their the corn oil was increased to 280%. They added a little bit also onto the saturated fat diet, but the most important is that they achieved 13% of all calories were with from vegetable oil, while for the saturated fat, it dropped to less than 8% compared to control, which was 18%. So they followed these patients for about 7 years, and this is the overall outcome. If you group them all together, there was no major difference in mortality. But if you look at people who actually were older than 65 at baseline, indeed, their cholesterol and LDL cholesterol dropped, but every 30 milligrams drop in serum cholesterol was associated with 35% higher risk of death. And this was highly statistically significant. As a matter of fact, if you look at all comers, and Dr. Ramsden put this together, it doesn't matter whether it was a control group or the treatment group with vegetables, or the higher was your drop in overall cholesterol, the worse was the mortality. So, and you'll say, okay, this is a bit ambiguous, but clear. Vegetable oil, not only that doesn't help, but if there is anything, it may hurt and worsen the mortality. But simultaneously, so happened, there was another study that was designed in Australia. It was called the Sydney Diet Heart Study. Almost 500 males who were randomized, double-blind, randomized to an intervention that increased the polyunsaturated fatty acids, linoleic acid, to about 15% of food energy, and correspondingly reduced their saturated fat to 10% of energy. And Dr. Ramsden from NIH, the same one who published this, and look at this, the overall impact was tremendous and very disappointing. 62% higher mortality in the linoleic group, in the intervention group, 72% higher cardiovascular mortality, and 74% worse coronary disease mortality. So this kind of disproved the hypothesis. And Dr. Ramsden, actually, who is a seasoned scientist at lipid peroxidation unit at NIA, has found the tapes of these studies that were published. They were done over 40 years ago, a few years ago. And then he basically put back the data. He actually was able to interview one of the main investigator for the Minnesota Coronary Experiment and ask, why you didn't publish this data? And he says, well, in short, we're disappointed about the results. So I think we need to know this and actually put this into a meta-analysis, all this randomized prospective study, and notice that if it was mostly omega-6 supplementation, actually the saturated fat was superior in terms of mortality benefit, while if they have mixed intervention where they added some omega-3 fat, maybe there was a tendency towards benefit. So
we have 5 minutes left.
All right. Despite this, American Heart Association still recommends that our main fat supplement in the diet should be liquid plant oils. I'm not sure why is that, but having said that, the American College of Cardiology actually have the opposite statement and position on this, which is, I think, very good. I was going to present you some of our data that we've done. We actually created a similar model by working with Dr. Frank Anania in the lab, and there's it's called the Alios diet, basically equivalent of a burger a day, French fries, and soda a day for these mice. But you see, the main diet was partially hydrogenated vegetable oil and 13% soybean oil with 2% fructose, similar to. And this model has been shown to induce obesity, fatty liver, dyslipidemia, inflammation, insulin leptin resistance. When we look in the hearts at 4 weeks, you get oxidative stress and recover these oxidized linoleic acid metabolites. They get insulin resistance in the heart when we measure it. They also have high insulin and high inflammation. And when we look at the hearts, they actually develop initially left ventricular hypertrophy and eventually dilated cardiomyopathy with an equivalent of ejection fraction about 40%. Is progressive over 12 to 16 weeks. When we look at the RNA profile of these mice, they switch to fetal phenotype. They they have insulin resistance and they're unable to actually utilize both fat, saturated fat, and glucose. They have dramatic downregulation of mitochondrial dysfunction, mitochondrial biogenesis. Dr. Anani actually was the first to test if he blocks the fatty liver. I was curious what happens in the heart. So improved fatty liver with the first time ever used GLP-1 receptor agonist liraglutide. And we're able to actually show that if you improve fatty liver, you improve the left ventricular hypertrophy in these mice. Now, based on this omega-6 on the Mediterranean Alliance heart study, that showed a 72% reduction in cardiovascular mortality back in '96, way before statins. What was the single most important significant was the change in this ratio between omega-6 and omega-3 from 19 to 4.4. So we tried to do the same in the mice. We added back omega-3 and want to see improved cardiomyopathy, changing this ratio to equivalent of 6.51 and 3.1. And to our surprise, basically, we improved not only the fatty liver, but also the cardiomyopathy here showed. And the obesity did not change, suggesting that probably most important mechanism how they work was through the anti-inflammatory, antioxidant. Similar study there when it looks to aortic atherosclerosis and aortas in LDL receptor knockout mice, high omega-6, bad atherosclerosis, add back omega-3 prevents atherosclerosis. And in a nutshell, I was just trying to say that when you combine this with fat, they help us, and we increase the high temperature, we improve our taste. However, that actually causes advanced glycation ending products and hemoglobin 1C. And for me, when I look at the patient and I see a hemoglobin 1C, even myself, if I see my hemoglobin 1C was 5 a few years ago and now it's 5.4, I take that as a marker that I'm getting more H products and my mitochondria are moving towards pro-inflammatory, pro-growth phenotype. And that's a hypothesis. And in ours, we do have a marker of oxidative stress that we measure every day. We can do it. I'm going to go to just the part I wanted to make one last point about.
We have to end because it's
okay.
Get to conclusion.
Okay, then we'll just take home points that I'll just say that omega rich, the supplementation of EPA actually works probably by being an antioxidant, anti-inflammatory. Ideally, we like to change that ratio, not just the total, to 1 to 4. I prefer to recommend for patients to eat marine fish. The fish oil supplements are highly oxidized, at least the commercially available one. So if we are to supplement fish oil in those who are vegetarian, I rather prescribe, if I could, a pharmaceutical grade one, which has shown is not oxidized. For secondary prevention, actually, I was going to show that really the mineral oil was not a big issue into the why we had that. I really believe REDUCE trial was actually effective in terms of IP supplementation, and unfortunately it's difficult to get it approved and it costs quite a bit of money still. But I recommend for those patients who are interested and they have secondary coronary disease to even triglycerides over 200 or triglycerides to age ratio of 2.5 to consider it if they had prior coronary disease, concomitant with really cutting the vegetables and the processed sugar. I'm going to stop here. So.
Great. Thank you so much for a wonderful presentation and for reviewing all the data related to omega-3s. In the interest of time, because we are over time, if people want to type in their questions in the chat, I will go ahead and ask you, Dan. So, just two quick things. Insulin sensitivity also has a circadian pattern to it, right? So I'm just wondering what you're telling your patients related to dietary intake, because you talked quite a bit about insulin sensitivity, and I'm just wondering if what your thoughts are related to that. And then the second question is, are you telling patients to just not take over-the-counter fish oil, given your last comment that it's highly oxidative?
Well, it depends if, all right, it's easier to answer the second one. I tell my patient to make every effort to eat marine fish 3 times a week. And I always use this example of 1 can of sardines got 1,700 milligrams of omegas, and you just get rid of the oil and squeeze some lemon, and it's easy to add in your diet. If they don't like that, they can eat salmon. I think that's probably the most robust way of doing it. And by the way, on this topic, American Heart this line aligns with the American Heart Association guidelines too. However, although they say only twice a week, the fish oil supplements, I reserve it only for those who absolutely insist, vegetarians or vegans, who no matter what, they will not take anything with fish. And often they prefer the vegetable form, which actually has been very little proven that actually it makes a difference. We actually now, you can measure the omega-3 index by, it's a kit from Amazon that Cleveland Clinic uses to about $70. You can actually, in some rare occasions to motivate my patients, I show them, hey, this is your baseline omega-3. Why don't you try it, and see if it makes a difference? And it did improve from 4% to 8%, which is what's recommended. So there are ways how to get around that. But no, I don't recommend the regular supplements unless it's a verified lab, and there are very few actually that have done their work and posted that they measure the oxidative substances. Yes.
Great. Any other comments or questions from audience?
Sorry, insulin sensitivity, sleep, circadian rhythm, very important. Actually, the #1 risk factors for insulin resistance is sleep deprivation. There's absolutely no doubt. Good point there. So another part that I encourage them to really respect their sleep. Is extremely important. This is when actually we burn the fat, most of the fat during the sleep. People who sleep less, they gain weight. It's a well-known fact.
Okay, if there are no other questions, and I'm sure when people think of questions, they know how to reach you, so you'll probably get emails. But thank you again, Dan, for always volunteering to give us these talks. And this was part 4, so I think this is the end of this series. Is that right?
I hope so, yes.
Thank you so much. And everyone, hope you have a wonderful week. Don't forget to get your CME, and I'll see you next week. Thank you.
The preceding program is copyrighted by Emory University.